I'm Bertrand Tombal. I'm a urologist from Brussels, Belgium, and I'm pleased to welcome you to this symposium entitled Advancing Patient Care in the Evolving Prostate Cancer Treatment Landscape. Thank you for those who are here and not in sunny Amsterdam on a boat drinking an ice-cold beer. I'm not sure I wouldn't do that, actually, if I was not speaking. So I'm not going to do that alone. I'm going to be actually helped by a team of German urologists. I think that's good because when we were in the discussion, they had a broad access to all the drugs, so their opinion will be extremely informative. Dr. Bogeman from Münster and Dr. Gratzke from Freiburg. So we're going to split the discussion between non-metastatic CRPC and metastatic hormone-sensitive prostate cancer, and then follow by case studies presented by Dr. Gratzke, and after that, a panel discussion. So having said that, I think that we can start right away with the presentation on Dr. Bogeman that will focus on non-metastatic CRPC and why we should treat these patients. So Martin, the floor is yours.
Right. Thank you, Bertrand, and hello, everybody, once again from my end. My task today would be to talk with you about the non-metastatic CRPC space. Can we improve overall survival and time to metastatic CRPC while maintaining quality of life? Here are my disclosures. And as you all know, probably better than me, 90% of the patients with prostate cancer have localized disease when they are diagnosed with prostate cancer. However, 10 to 20% of the patients will be diagnosed with castration resistance during the course of their disease. And that takes about approximately 5 years of, that is after approximately 5 years of follow-up. And the most severe stage of disease in prostate cancer, as you all know, of course, as well, is the metastatic castration-resistant prostate cancer. And this worst stage of disease is reached in about 86% of the cases over the stage of the non-metastatic castration-resistant prostate cancer. And most men with metastasis progress to CRPC within a median of 1 year. So that's the stage we are dealing with. And of course, as you can see on the diagram, there's lots of ways in which you can reach the non-metastatic CRPC and eventually the metastatic CRPC stage. And for the patients we treat, we have a situation of patients who only have ADT in the non-metastatic CRPC. So they will have a relatively good quality of life, aside of hot flushes, for example. And so we have several things which are important. We have to extend the overall survival, of course, because that's the ultimate goal, and it's most important for the patients to survive as long as possible. But that at the same time needs to go along with tolerability. So we need a compound that we use to treat our patients that is okay for the patients to take, maybe for a long time. And so the patient's ultimate goal, next to surviving, is to live their life uninterrupted, as they do in most cases when they come into the stage of non-metastatic CRPC. And not depicted here on this slide, of course, there is a PSA anxiety. So patients learn from their urologist in the practice at home after they had radical prostatectomy that your PSA level needs to be at 0. But that, of course, sometimes is not the case anymore, and so they are very scared. And they sort of build up pressure for themselves, but also for their urologist, who, of course, then want to treat. And here you see the natural history of the average patient. And let's imagine we have a patient here who had radical prostatectomy, and he benefited for a while, and then he relapsed, and he got salvage radiotherapy, and he had some benefit once again. And after a while, you have a situation of a steeply rising PSA, and you probably will start him with ADT. And once you have done that, patient will, in most cases, respond once again. And then, after a while, the patient becomes castration resistant, and then you have non-metastatic CRPC in case patients didn't develop metastasis so far. And that works for a while as well, but after a while, as you can see here, the PSA progresses rather steeply. And if you don't do anything about that, the patient will develop metastasis and will become symptomatic, and then he will get all the good stuff we treat the patient with in metastatic CRPC space. And patients will develop this metastatic CRPC disease earlier if they have a shorter PSA doubling time. As you can see on those two graphs, if you have a very short PSA doubling time, as you can see here on the left-hand side, the orange graph depicts patients who have a PSA doubling time of 3 months or less, and they have a really high chance of developing metastasis. On the right-hand side, you see that patients who have a doubling time around 8 to 10 months are those who are still rather okay, but if they have an even shorter time of doubling time for the PSA, the curve inclines very rapidly and is associated with metastasis or death. So maintaining the patients in CRPC, a non-metastatic CRPC, while having a very short doubling time is the ultimate goal. Why is this important? If we have patients who have non-metastatic CRPC, they will have a risk of dying within 1 year of 16%, while if they have metastatic CRPC, this risk rises to 56%, which is a dramatic difference. And on the right-hand side, as you can see here, we have a 5-year survival of 56% if the patients don't have bone mets, but once they have bone mets, this 5-year survival decreases to only 3%. So that's very important to keep patients away from metastasis. So these are the 3 drugs we now have. We have darolutamide, we have enzalutamide, and apalutamide. If you look at enza and apa, you will see that the structure of the molecule is rather the same. You will need a while to find the differences, I guess. And if you look at the left-hand side, you see darolutamide, and you see that the molecular structure is really different. We have a flexible linker, which allows the compound to more effectively cuddle into the niche of the ligand-binding domain, and this may be part of the reason why it is very effective. And this totally different structure of the compound may also be the reason why the compound does not enter the brain so well compared to enzalutamide or apalutamide. As you can see here in the rodent model, it could be seen that darolutamide only penetrates the blood-brain barrier like 8% compared to about 80% in enza and apa. And you will, of course, say that's only rodents. But if there was a study which has been done on the cerebral blood flow in a healthy man who received enzalutamide, darolutamide, or placebo, and it was seen that the patient blood flow was about on placebo niveau for the darolutamide-treated healthy males, and this may be an indication why the central nervous system toxicity is so well with darolutamide. And darolutamide, unique structure, may also be one of the reasons why the drug-drug interactions is so different compared to enzalutamide and apalutamide. So there were 3 phase 3 pivotal trials which have been done. We have Aramis for darolutamide, we have PROSPER for enzalutamide, and we have Spartan for apalutamide. And in all of these 3 trials, about 1,200 to 1,500 patients were enrolled. All were high risk because of the very low PSA doubling time of 10 months or less, and they received one of the 3 new anti-androgens or placebo, of course, in both cases combined with ADT. The primary endpoint was metastasis-free survival, and the most important key secondary endpoint, of course, was overall survival. Here you see the overall survival for the patients in the Aramis trial. Once again, that's the trial with darolutamide. And you can see here in the final analysis that the hazard ratio was 0.69, representing a 31% reduction of the risk of dying within the course of the trial. And as you can see on the right-hand side in this forest plot, you see that all relevant subgroups have a very good effect concerning darolutamide because the median values are well on the left-hand side of the 1.0 line. The other two compounds, Partin for apalutamide and Prosper for enzalutamide, worked as well concerning OS benefit. So we have three substances which are very effective concerning the efficacy. And the primary endpoint, as you will remember, was the metastasis-free survival. And you can see here that for all three compounds, once again, we have very comparable results concerning median times to metastasis compared to placebo, and also comparing the hazard ratios. Of course, those endpoints are not the only things which are important for the patients, but you have also more softer targets, like the time to cytotoxic chemotherapy, which was significantly improved for darolutamide and for apalutamide, or the more or less the same endpoint, the time to antineoplastic therapy for the patient treated with enzalutamide. And as said, patients are very scared of the rising PSA level, and so the PSA changes are very important. They are paramount, I would even say, for the patients. And you can see here in those waterfall plots that the median change of darolutamide-treated patients in non-metastatic CRPC was minus 87.4% PSA-wise, while the median change was plus 47% for the patients getting placebo, which was the hitherto standard of care, waiting for metastasis for the patients to be seen. So the anxiety can be helped with by treating the patients with darolutamide, for example. And then you, of course, need tolerability. And the most important thing, in my opinion, to compare compounds concerning tolerability is the rate in which patients stop doing the drug on a trial. And as you can see here, the discontinuation rate for darolutamide and Aramis was on placebo level with 8.7 versus 8.9%, while apalutamide and enzalutamide treated patients had about doubled discontinuation rate compared to placebo. And the same is true for the incidence of adverse events of interest. There's the fatigue, we have falls, we have fractures, we have rash, we have cognitive and memory and mental impairment, we have hypertension. It's all side effects which are very known for androgen deprivation therapy using androgen receptor inhibitors. And as you can see here, in of course indirect comparison, that the patients treated with darolutamide have a very low incidence rate of those side effects compared to patients in this Partin and the Prosper trial. And if you ask the patients by doing the quality of life questionnaires, they tell the same story. They sort of voted by ticking the boxes in the quality of life questionnaires, and they came to the result that they sort of liked darolutamide better than they liked placebo. So the quality of life is really good from the FACT-P questionnaires. And if you imagine a patient who, for example, got his primary tumor being radiated by our friends from the radiotherapy department, and after a while the patient recurs and he's like not suitable to get salvage radical prostatectomy, and then he may develop local symptoms like bowel symptoms and urinary symptoms. Which could be stools bloating, blood in the stools, blood in the urine, and all sorts of things which you as urologists all know, and which are problematic for the patients and you as urologists to treat them. And those patients will have a better fate, which is depicted here in this slide if they take darolutamide in the non-metastatic CRPC space. Because patients who are in an CRPC space will have at least partly in the prostate in place, and they will have problems because of that, and that is helped with darolutamide compared to placebo. And this is, of course, also true for apalutamide and enzalutamide. In the left-hand side, you see the quality of life curves for apalutamide, and on the right-hand side, the quality of life curve for enzalutamide in the PROSPER trial. And here also, you can see that the patients have a very good quality of life for APA and ENZA as well. So, coming to the end of my talk, we can extend overall survival, which is the overall goal for all patients, losing darolutamide, and that goes along with a very, very good tolerability for the patients. And they have a side effect profile which is almost on placebo niveau. So they can go on with their life uninterrupted, and they can alleviate or their anxiety for PSA can be alleviated. So I think losing darolutamide in the non-metastatic CRPC space is very useful for the patients we treat. And that's the end of my talk. And I guess we go on and discuss later on. Okay.
So I'm now going to review the metastatic hormone-sensitive prostate cancer, and then we will have clinical case discussion. So here are my conflict of interest. So what we're going to speak is a little bit how we came to the modifying the field of newly diagnosed metastatic prostate cancer. We're not going to focus, so this has been already addressed by Martin, and this actually is the state of where we are in treating metastatic CRPC, although later on we may discuss what we do when the patient progresses on one of these drugs. So I decided to take a historical perspective to see a little bit what are the questions we have still left today. So I remember being a young resident and doing hormone therapy, but for years the only treatment of patients with newly diagnosed metastatic disease that was very easy. You would either recommend an agonist, an antagonist, or even sometimes surgical castration, and these patients would progress, then become castration resistant. Actually, everything changed with the publication of the CHARTED trial, and roughly at the same time, the GTUC15 trial. They actually investigated the role of docetaxel on top of ADT in these patients with metastatic hormone-sensitive prostate cancer. The CHARTED came very positive with a risk reduction of 40%, while the French trial was actually negative with a hazard ratio of 0.88. Still today, it remains a partial mystery trying to understand why it was positive and the other one negative. So for a few months, we lived with some uncertainty, not knowing which one was actually the good one. And many times, when it's like this, you need a third trial to really adjudicate. And what is very interesting, if you look at the STAMPEDE trial, which actually mixed non-metastatic and metastatic patients, you find that the hazard ratio lands just in the middle of the two other one. But actually, when you perform a meta-analysis, and you're going to see how much these meta-analyses are important later on, it was concluded, and it's still the case today, that docetaxel significantly increases overall survival in patients with metastatic hormone-naive prostate cancer. So that was, it's not two studies, it started with 3 studies actually showing that docetaxel works very well. The problem of docetaxel, though, at that time, already it was a chemotherapy, so a little bit more complicated to give, in a treatment landscape that was absolutely dominated by urologists. So to me, if you ask me 15 years down the line, what was the benefit of docetaxel, I would say that beyond increasing overall survival, this has been really the tipping point for multidisciplinary management of prostate cancer. Because for the first time, we had to sit down with medical oncologists and together discuss what was the best treatment of patient. And that was not a given. I remember going to speak in Spain in 2015 about the docetaxel result, and 2 conferences were organized. The first one was with urologists, and the second one was medical oncologists. I gave exactly the same lecture at 2 hours interval, but Sanofi at that time couldn't find a way to put everybody in the same room. So that has been really the big benefit of docetaxel. That was the start of the management, multidisciplinary management of prostate cancer. If you look at what chemotherapy does to the quality of life, you see something interesting is that in the first month, you could read that as chemotherapy deteriorate the quality of life. That's absolutely not true. That is linked to the transient side effect and burden of chemotherapy. But you see afterwards, the benefit of chemotherapy on the tumor makes that patient don't progress and quality of life improve with time. Then the guidelines started to be changed. It was the time where, for the first time, they said that actually you should combine ADT with chemotherapy to every patient whose presentation was M1, which was something very interesting because when it comes to chemotherapy, there is clearly a volume timing effect. We have learned a lot since then, and nowadays we actually do stratify patients in low volume, high volume, and whether the metastasis is synchronous or it happened at recurrence and it's called metachronous. You can use various definitions. None of these definitions were prospectively validated. They were actually taken as this, and validation came much later on. The charted definition was a simple one based on the number and distribution of bone metastasis and the presence or absence of visceral metastasis. Then the investigator of the Latitude trial, Latitude being a registration trial, came with a slightly modified definition that also includes Gleason score, however needing more than one criteria. So this was actually very interesting because when we started to look at the benefit of docetaxel in these patients, there was indication that docetaxel was actually especially positive for patients with high volume disease. So this is a topic that has been well studied, but this is the latest meta-analysis by the StopCap group in London. Why I value this one more than other? It's because it's done on individual patients. So all the collaborative group who participated to this trial, Charted, GTOC, and Stampede, put their data in a large biodepository. And what it shows is that docetaxel benefit to most of the high volume, all the high volume, whether they are synchronous or metachronous. Its benefit to the low volume, this is mostly driven by Stampede, but there is absolutely no benefit for the low volume metachronous disease, meaning that if you had a radical prostatectomy 5 years ago, and then suddenly your PSA start rising, you are asking a bone scan and it shows 1 or 2 bone metastases. You will not benefit from docetaxel. But that's the only group, meaning all the other groups still benefiting for docetaxel. Later on, we will discuss about the high risk, low risk, high volume, low volume, and the question being, is there low volume patients that are benefiting from the addition of docetaxel? And I used to always quote the case of a young patient showing up with a Gleason 10 T4 big cancer lymph node. Actually, he had no bone metastasis, only large lymph node invasion. But actually, this patient would qualify for docetaxel because that same meta-analysis showed that in patients with high volume CT4 lesion, and also in patients with low volume CT4, there is some benefit of docetaxel. So we're going to have to refine that definition. But clearly, when it comes for docetaxel, volume and timing matters. But then everything changed. Everything changed with, as it changed in metastatic CRPC with the arrival of enzalutamide and abiraterone, it also changed with a study investigating all the androgen, all the AR pathway inhibitor, apalutamide, enzalutamide, and darolutamide. And within 5 years, we had actually confirmation from 5 trials that adding an AR pathway inhibitor to androgen deprivation therapy very significantly increase overall survival. And when you see the reduction we have, it's in the 40%. So, you know, it's kind of very, very significant. There is a caveat though. This trial had mostly a patient with high volume. Here it was a broader inclusion criteria. And that's the major difference between ADT plus hormone therapy and ADT plus docetaxel, is that so far, in ADT plus one of the ARPI, we haven't shown an effect of volume or timing. So notwithstanding volume and timing of metastasis, AR pathway inhibitor will increase the overall survival and all other endpoints of patients. So I think that as a first step, we should recognize that as for today, anybody that presents with newly diagnosed metastatic disease by conventional imaging, and we'll discuss later on what new imaging technology is adding, these patients should be intensified. We are far from this. When we look at real-world evidence, it's mostly 50 to 60% of the patient. But I think that as a reasonable target for the next year is really to secure that. And actually today, it is recognized by the guidelines that you should offer ADT combined with abiraterone, apalutamide, and enzalutamide. It hasn't been reviewed yet for darolutamide, explaining it's not there. It's an option. And that's been actually all we lived in the last, I would say, 2-3 years. And every single MDT was discussing who needs chemotherapy, who needs hormone therapy. How do we select that patient for docetaxel? How do we select that patient from hormone? We came with a lot of things. We tried to define the ideal docetaxel patient, not very successful. We tried to speak about convenience. We tried to speak of a lot of things, but we couldn't come, so every MDT. Then, unfortunately, during COVID, it changed a little bit because there was some kind of docetaxel bashing, saying that you should avoid the patient. So I think that, unfortunately, that discussion has faded away during the COVID period, and nowadays we can clearly say that the number one recommendation is, the number one treatment we see out there is ADT combined with one of the hormones. Then piece 1 and Arasens are investigating the triplet. And I think here we have to come back to what was the question. Keep in mind that when you see the result of a trial, that trial has been designed 5 to 6 years ago. So when we designed the trial with Bayer in 2014, 2015, the question asked by the steering committee was not about the triplet. It was about if you considered that a patient requires ADT plus docetaxel, is there room to add one AR pathway inhibitor? So if you consider that the patient is ADT plus docetaxel, should you add something? For us, from start, darolutamide was an optimal agent to do that because very little drug-drug interaction. And from what we knew at that time, from the phase 2 and the beginning of starting to have result with the molecule, it was extremely well tolerated. And we knew already from 22 trials in castration-resistant prostate cancer that docetaxel was a very, very difficult bride to get married. It's a molecule very difficult to combine. you rapidly have additional toxicity, you lose efficacy. So it was very important to find a molecule that would allow us to deliver docetaxel safely. At this point in time, we were not speaking too much about high volume, low volume. You remember that the Gwenel-Gravis paper came in 2015. So we basically stratify patient by M1, A, B, C, and also use alkaline phosphatase because as a single biomarker, it had been shown already to be the strongest predictor of outcome in these patients. They were therefore not stratifying high volume because the question of that trial was not who need docetaxel. The question was, assuming your doctor has decided that you need docetaxel, can you do it alone or not? So the result has been published in the New England. There have been many reports already, and everybody was kind of scared because we had the result of the ENZA-MET trial, where adding enzalutamide in that setting didn't improve significantly overall survival in the high volume. We had the result of the Titan, but in the Titan it was a sequential use, so you'd give ADT plus docetaxel and then you consolidate. No, we wanted to do something very pragmatic. You start your patient on ADT, you start darolutamide the next day or 2 days after, like you would have started your bicalutamide 5-6 years ago, and you start your chemotherapy like you do in real life. And doing that, so concomitant, very easy, very significant improvement in overall survival with a hazard ratio of 0.68. That is a 32% reduction in the risk of death, with a median overall survival which is kind of in line with the study like Charted or other. Keep in mind that these are probably, and we're going to see that later on, they are probably high volume, high-risk patient and patient with aggressive disease because they were selected for docetaxel. When we designed the trial, also with Matthew Smith, we say, no, we want a very simple trial. We want just to go for overall survival. Then we decided not to have too many complicated endpoints, but to have what we call clinically relevant endpoints, such as when do the patient become castration resistant, time to pain progression, symptomatic skeletal event, time to SSC. No, you don't need to be a genius to understand that if you have such a big effect on OS, you won't see any of the endpoint that would not be positive. So basically, all the endpoints are important. Very important, as mentioned, we wanted to have something that allow us to give docetaxel safely, and you see that in the trial, 87 and 85% of the patient could receive the 6 cycle of docetaxel, which was the benchmark established by Charted, so very effective to do this combination. In terms of toxicity, you find something we will discuss later on with however you measure the toxicity, you don't see a major difference between the placebo and darolutamide. You see some toxicity. Yes, it's normal. It's ADT plus docetaxel. So you see the same toxicity you would see in Charted in GTOC 15, or that you would see if you have to give docetaxel later on, because keep in mind that many of these patients will have to receive docetaxel later on. Here, we have what I call a near placebo effect. And whatever side effect you look at, there is fatigue, there is flushing, there is rash, but you don't see any significant detriment from adding darolutamide. It's always virtually the same than the placebo. When it comes to docetaxel, very importantly, there is no increase in the toxicity of docetaxel, something which is very important. If you look at other concurrent trials, you will see that in some of these trials, they had to reduce the dose of docetaxel to make it tolerable. This is not the case here. So that was where we are now. So basically, we can say one important thing is that probably we should revisit the EA guidelines. They're very curious to see what they're going to say. At least we answer our question. The question was, is it enough to give ADT plus docetaxel? If you have DARO or ABI, because we haven't speak about piece 1, but we could do it as well. The question is no, ADT plus docetaxel enough. So that study is practice changing at this regard. But now the question is more complicated. Who need triplet therapy today? Because the time has changed. So this is something we may discuss later on, but rapidly, if we look at the APCCC, and we look at recommendation for the treatment of synchronous high volume metastatic HSPC, you see that 40% recommend the triplet. There is a striking difference with another triplet, which is triplet of adding local therapy on top of ADT in low volume, but you see that in the low volume, there will be more triplet, but docetaxel clearly, as suggested, has no efficacy. Then the question is, can we compare these AR pathway inhibitor once with the other? That's a tricky job because basically they all use different patient population. It's slightly different in the way the side effects are measured. So you have to be extra careful about that. But I would like to use very simple metrics. A very simple metric is the proportion of patients who discontinue the treatment due to adverse event, because that's important. It means that whatever side effect happened, the doctor or the patient decided to stop the treatment. And you see that when you use darolutamide alone, and this is what Dr. Bornemann saw, I mean, there is basically no difference with placebo, so very few patients stop the treatment. And actually, if you compare that to the PEACE 1, for instance, where 16% of the patients decrease or stop the treatment, here we are, we only have 3% of the patients who stop the treatment. So once again, it highlights how much it's convenient to combine. When you look at apalutamide and enzalutamide, there's not big difference either. So once again, you have to be careful when interpreting this. Already said, darolutamide is a different molecule. It doesn't cross the blood barrier, and that probably explains what we see here in terms of side effect. Beyond that, there are other things to be discussed. Abiraterone is a great drug, but we all know it's a little bit more complicated to use than the amide, APA, and darolutamide. So that's why I think that in the future, this is probably going to be price-wise, these three molecules, because they are very easy to use, especially for urologists. The monitoring is very simple. Keep in mind with ABI, we had to see the patient every month. We had to do a lot of blood sample. We had to monitor a lot of things. With APA and ZA, once you've checked for DDI, something you may not even have to do at the same level with darolutamide, they are more easier to administer. That's something we may underestimate. This is the importance of the drug-drug interaction profile. It may explain a lot of things. The absence of drug-drug interaction may explain, with docetaxel at least, why we have such no impact on the docetaxel alone. But if you look at typical patient, you're going to recognize a lot of drug here. And you should be really careful that when you combine any drug with one of these agent here, you want to be sure that it doesn't increase or decrease. And one good example is, for instance, rivaroxaban, which is something that's going to be prescribed for somebody who has a cover stent. You have to be careful that a result of drug-drug interaction is that although the patient is taking his drug, is not covered anymore. So drug-drug interaction, this is something objective. Toxicity, that's not very objective. We can't compare. It's not a fact. It's an observation. And if we want to compare the three drugs, we're going to need trial, preference study. We're going to have to make our own experience. This is factual. This is fact. If you are on a patient on clopidogrel and you're starting darolutamide, it's not going to be exactly the same that's starting enzalutamide or apalutamide. So you have to be aware of that. So take-home message, docetaxel, abiraterone, and enzalutamide were first established as standard of care for metastatic CRPC, then have moved now. Immediate intensification of ADT with an AR pathway inhibitor is now the standard of care for metastatic hormone-sensitive prostate cancer and should not be delayed. That should be the first effort. I think that beyond that, there's a question to be discussed, is the additional intensification will triple combination treatment, especially with docetaxel. This should be considered also a standard of care, and we may discuss later on who are the patients we believe are fit from that. I think that DDI profile is important. It makes darolutamide different from other AR pathway inhibitor, and this is a fact. And that's important in elderly prostate cancer with polymedication. Favorable toxicity profile, convenient management, and different DDI, they are relevant consideration, but we're going to have to use each of these drugs individually to really understand their benefit and make a final choice. Thank you very much for your attention. And we can now start the case study with Dr. Gratzke.
Thank you very much. Thank you for the invitation, and I'm happy to share some very pragmatic clinical cases in how to deal with NMCRPC and metastatic hormone-sensitive prostate cancer. My disclosures. So I think we all share the same key treatment goals for men with MH, SPC, and NMCRPC. What we all would like to achieve is to extend survival, we've heard that, and delay progression to MCRPC. We would like to minimize adverse events to achieve good tolerability and also preserve long-term quality of life. I think maybe quality of life preservation now has become a major issue. Patient-reported outcomes are more and more important, which I think is really a key criteria to judge the success of a certain drug. Now, I would like to present to you first a patient that actually had a big impression on me. I came to my department as a chair 4 years ago. I wasn't there very long, and then a colleague from town came in, and he just wanted to see who I was and to get to meet me. And he was 44 years old, the same age that I was at the time. So he came in, and then he told me that his father was diagnosed with prostate cancer, and he had had surgery and was doing well. So I said to him, look, while you're here, why don't we check your PSA as a baseline? That was his first time, and we did. I was expecting, of course, a very low value. It came back with 18.2. I was very surprised. And what I usually do in those young patients, I repeat it a month later, following a 3-day course of antibiotics, it was 19.0. So, of course, I talked to the patient. For both of us, it was, of course, a surprising and shocking, PSA level for the guy. So we did a multi-parametric MRI of the prostate, finding a Pirates 5. So we discussed the results, went on to do a biopsy, a fusion biopsy, and found adenocarcinoma of the prostate, Gleason 9. 24 out of 29 biopsies were found to be positive, 70%. So, and we touched upon the topic of imaging already. In that scenario, which is a high-risk prostate cancer patient, at primary staging, we would do PSMA PET scan imaging. I think guidelines will recommend 2 stages to do PET scan imaging, which is that scenario, primary staging, high-risk patient, or recurrence, where a PET scan really makes a lot of sense. And I think in that scenario, it is extra important because a PET scan will lead you the way. It decides, the way to go from the beginning. So we did this PET scan, and we found bilateral PSMA expression of the prostate with infiltration of the left seminal vesicle and with a broad contact to the rectum. I did palpate, of course, the prostate. The mucosa did shift a bit, so it was a very significant result. Suspicious of prostate cancer, of course, increased PSMA expression of the multiple enlarged lymph nodes in the iliac fossa bilaterally, and pre-vesically suspicious for malignancy and high PSMA expression of a hypodense lesion of the urinary bladder, and I'll come back to that in a second. And this is what the pictures showed us. You see here on the left side this very tissue sort of intruding into the bladder almost until the trigone. And you see on the right side the lymph nodes shining up on both sides of the pelvis. So now we are faced with this critical situation, discussing the way to go. And whenever this is the case, we go to an MDT, which we are obliged to do, and discuss the patients with our colleagues. And the patients opted for a radical prostatectomy with extended lymphadenectomy, which we did. Histology came back, not surprisingly, lesion 9. He had a T3B, as PET scan was already alluding to T4 in the urinary bladder. That was a very difficult, it was a very soft and smushy tissue extending into the bladder where the margins were not very clear. It was difficult to resect. That's why the margins were not clear at final pathology, and he had 11 positive lymph nodes out of 40 that we took out. 8 weeks later, we do the first PSA. It dropped from 19 before to 0.71 nanograms per mils. So we discussed this patient again in our multidisciplinary tumor board. And here now, of course, we have a very good access to PET scans. If you ask yourself the question, why is he doing a PET scan again? Whenever we talk about those patients with the radiotherapist and the PSA is above 0.2, also for academic reasons, they will want to have a PET scan. So we did one. And we found that PSMA expression was, again, suspicious for malignancy of a slightly size progressive lymph node at the iliac fossa on the right side. Status post-lymphadenectomy without evidence of further suspicious lymph nodes. So I think we did a probably fairly good job, but not good enough, because you see the right side, there's still a lymph node shining up. You see minimal PSMA expression in the prostate, urinary bladder with a follow-up recommended. So we discussed the patient again and start ADT. He receives radiotherapy to the prostate bed and the lymph nodes with a boost on PET-positive lymph node at the right iliac fossa. Now, we've done surgery, we've done radiotherapy, and we measure PSA. PSA goes down as expected. It goes down to a nadir of 0.04 nanograms per mils. But then 2 months later, it starts rising again to 0.06. And then already in August 21, it was 0.22. Now, you're faced with a patient that is really young and now starts to get very anxious. He was pretty solid throughout these stages, did everything that we discussed. But now, with having undergone surgery and radiotherapy and now seeing a rising PSA, he asked for another PET scan, which we did. And then we saw less PSMA expression in lymph node, but still vital tumor remnant suspected. No evidence of further pathological PSMA expression on any other side, at least. So even after a surgery and radiotherapy, this lymph node is still lighting up. You can see this here in this section of the PET scan. So the question is now, what are we going to do? And we discussed this again with the patient. Difficult situation. One option would have been salvage lymphadenectomy. In our department, we've done many salvage lymphadenectomies. I think there is a common agreement now that you should do it, or you can do it, if you have up to 3 lymph nodes at a very specific area of the body in the pelvis. So that would be an option in that patient. I personally don't have the best experience from salvage lymphadenectomies because we did a lot of them with maybe just achieving a PSA cosmetic. But that was one option. There's another option of now intensifying systemic treatment. Patient has systemic disease. Why not intensifying treatment right now? Or you could just control, of course, the patient. So we discussed that, and I didn't want to do a salvage lymphadenectomy, even though technically that would have been not that hard. But he went to a different hospital, and he actually did receive salvage lymphadenectomy. It was a very uncomplicated surgery, minimal complications, and he did fresh frozen section, and they found adenocarcinoma of the prostate. And so they found the lymph nodes, which was the goal of the operation. Patient was very happy. So he came back, got another PSA checked. PSA actually from 0.22 didn't decrease, but it actually increased to 0.24, which was a huge frustration for the patient. But maybe not that unexpected. I think that's a patient where we always are lacking behind the dynamic that we just did not anticipate at the start. Enough, maybe. So 0.24, the question is, what are we doing now? So we do another PET scan. We found new onset liver metastases. We didn't really want to believe that. Did a biopsy. It was confirmed prostate cancer. And now, of course, having visceral disease, we put this patient on a protocol of Aresens, start him on ADT with docetaxel and darolutamide according to the protocol. We've already completed 3 cycles of docetaxel. The patient is doing fine. I saw him this week. He lost all his hair after the first cycle. He reacted very sharply and rapidly to docetaxel. This week he had a lymphedema of the left leg. We ruled out a thrombosis. He didn't have one. He's very brave. He's going through a tough time, but it's okay. And he's actually determined to fulfill all 6 cycles of docetaxel. And he has expectation, of course, once that is over, that under ADT and darolutamide, he will be able to achieve good quality of life. And that's the way we're going right now. We're already have planned our next cycle, docetaxel. And then after we have done all docetaxel, we will wait for 3 months before we do the first imaging with a PET scan again. That's the state where we are right now with this patient. And Bertrand, I have a second one on NMC-RPC. I'm not sure if you want to discuss the first one on MH-SPC first, or I would show the second one.
We can do both and then discuss.
Okay. So that was my first patient. And my second patient, that's a shorter case, actually. He's more straightforward. He is 68 years old. And that's a typical patient. Who has no family of prostate cancer. He has had regular PSA checks for about 10 years, normal range. He has minimal comorbidities, some cardiovascular comorbidities, but not significant. He has a medication according to his comorbidities. But then, all of a sudden, at one visit to the urologist, his PSA increased to 6.55 nanograms per mils. He gets the MRI. He has a Pirates 4. We do a biopsy. Biopsy reveals ISO 4 and 6 of 12 biopsy cores. So we do imaging. This is August 2015. So at that time, we didn't have PSMA PET scan. We had FDG PET scan. Before, or about 2 years later, we received a PSMA PET scan. So we did, according to existing guidelines, conventional imaging, and we saw a locally advanced cancer, but no metastases. So he has a high-risk, locally advanced prostate cancer, no metastases. And we discussed the options with him, and we start discussing what we can offer. Patient adopts for the option of undergoing radical prostatectomy with lymphadenectomy. Turned out to be a T3A, negative margins, ISO 4, and no lymph nodes positive. Patient did recover pretty quickly and pretty well from the surgery and lived his life. Before 2 years later, there was a PSA recurrence of above 0.2 nanograms per mils. So according to guidelines, we put this patient on radiotherapy and ADT. In May, a little later, PSA drops to 0. So following surgery and radiotherapy, PSA drops. It wasn't much later, only a little more than 1 year, that the PSA began to rise. Again, here now above 0.2 nanograms per mils. And you see the way the PSA went. And we discussed the options now with the patient, and we measure testosterone. He's now at castrate levels. He has a very short doubling time of 2 months, and we do conventional imaging again. We again saw no metastases, positive for local recurrence, small lymph nodes in the pelvis, and we discussed the options. The patient is actually doing well. But of course now he's anxious, and following the Aramis trial, where we were actually a center for, we put the patient on darolutamide. We've had good experience during the trial, and we proactively discussed the options, had some concerns, but then it decided that it was worth the risk. We did the scans according to Aramis protocol, 16-week scans, and we saw that the lesions were actually progressively shrinking, no new lesions apparent, which was good. He actually did not have any side effects. So patient quality of life was really good. He was happy to continue on the drug. He underwent regular imaging, which didn't reveal any new metastases. He felt well. He felt after 3 years of treatment, only minor side effects of fatigue. He associates that with his age. He then actually only recently moved to northern Germany. He just sent me an email saying he's doing fine. No new progression and nothing that actually terrifies him. So he's still on darolutamide, waiting for his next imaging. So that was my second case.
Thank you.
Thank you.
Before we discuss together, is there a question from the floor? No? So we will start with the non-metastatic CRPC and the role of modern imaging, because for both there is clearly a role of modern imaging. So what do you do now? So you have assuming you have a patient which has a rapid PSA progression and on ADT, he had like radical prostatectomy, then progressed, then had some hormone. What do you change your mind if what is the impact if you do a PET PSMA? We know that if you do PET PSMA, it's more than 50% of the patients who have metastasis. How does it change your approach of this? Like you show, Christian.
So
Yeah.
I think the discussion very much evolves around the availability and the access to novel modern imaging. In our center, we are fortunate that we have access to many slots of PET imaging. Of course, it's not like in Australia where pretty much everybody with a prostate cancer receives a PSMA PET scan, but the access is getting better and better, which is, I think, also due to the fact that now with lutetium treatment, the slots are more and more available. If you have, in the perfect world, access to novel imaging, you might as well use it. This is like Michael Morris said this year at the ASCO, so if you have the option of having the best modality, why wouldn't you want to use it? But I am aware of the fact that that's not the case everywhere. And of course, you can discuss it both ways. If you have a patient in that scenario that Bertrand just described, with the horizon of having metastasis-free survival of more than 2 years with conventional imaging, you have the option of giving him a drug with a good quality of life where the patient can continue to live his life as expected. And you don't need to have novel imaging, which is actually very attractive for the doctor and the patient. So the question, do you want to have modern imaging? Maybe not that critical because you don't need that to know that you have a drug that will carry the patient over the next years with a good quality of life. That's my impression. So of course you can argue you do novel imaging at every patient, but do you need it if you have a good option with conventional imaging? I don't think so.
Martin.
Yeah, maybe to add on that, as you said in your question, Bertrand, you have a high chance of about 50% in a potentially non-metastatic patients to find metastasis if you use a PET scan, as shown in the Spartan-like population in the trial of Iber et al. So in the Spartan trial, which is, as I showed to you, perfectly comparable to Prosper and to Aramis, patients were included only using conventional imaging. They didn't use PSMA PET. But in a population which was potentially non-metastatic CRPC, and all of those patients got PSMA PET, you would find a PSA source in almost all patients, in more than 90% of the patients. And as you said, in 50% of the patients, you would find METs. So those patients would probably not be included in Spartan anymore, and in Aramis and in Prosper. So why would you use a PSMA PET in this constellation if you sort of avoid the possibility of using a very tolerable drug, which maybe not be used in the aftermath? So if you use a PSMA PET and you find METs, you can't use darolutamide anymore because it's not approved in the mCRPC space.
What is very funny is that before we had the result of this trial, a patient on ADT that was having a rise in PSA, we would have had bicalutamide, not even asking a bone scan or a CT scan. So to me, yeah, I understand the drugs are more expensive. They're not much more toxic. There have been 2 trials with enzalutamide, Terrain and Strife, that show that it's not much more toxic. But then suddenly, because there is something kind of magical in these 3 drugs, we start asking a lot of questions where for years the guy would come, my PSA is rising, yes, that's a prescription of bicalutamide, that's it. So maybe we're pushing. Then what I'm going to do, I'm going to assume that people are doing PET PSMA, because now they're doing even PET PSMA for low-risk prostate cancer. So assuming you have a PET PSMA, I'm going to make 2 or 3 proposals, and you're going to tell me if it's wrong or right, okay? The first one is, okay, the guy is like your patient, he's got a PSA doubling time of 7 months, kind of significant. The guy is good shape. I do a PET PSMA. The PET PSMA is negative, and based on this, I decided I'm going to defer the start of one of these 3 drugs. Is it good? Is it wrong or right to do that?
I mean, wrong and right is a hard word, but I think why would you wait if you had a drug that is able to prolong survival and metastasis-free survival foremost, with a good quality of life? There is no real good argument to do so. So I would say it's wrong.
Okay.
I agree. So as I showed in my talk, you have a high chance of developing metastasis, and once you develop metastasis, you have a higher chance of dying over time. So you have a high risk of, with a doubling time of 7 months, you have a very high risk of developing metastasis shortly, even if you have a negative PSMA PET scan. So why wait?
Also another thing we see is that I saw 3 weeks ago a guy I didn't know he had prostate cancer, came to see me, traditional history, had prostate cancer, prostatectomy, radiotherapy, rapid progression. He had a PET PSMA that was negative 3 months ago. He was deferred treatment. He come to me 3 months ago with another PET PSMA because his PSA has doubled in 3 months. He's got 1 large metastasis on the hip, and the doctors say, oh, we're just going to do radiation therapy, we're going to defer treatment. I guess for you that is wrong also to do that.
The role of radiation has evolved over time, and many radiotherapists are becoming pretty, when I say aggressive, I mean very proactive in radiating a lot of sites where our guidelines don't really tell us that is actually having an oncological benefit. And if I have systemic disease, I would have a very easy rationale in saying you need systemic treatment as well. Radiation still, in most cases, would be good if a patient is in pain, if you irradiate a bone, or has a risk of fracture. But he would need, I think, systemic treatment. It would be helpful.
So can we conclude that we don't need new imaging to decide whether the treatment should start the treatment or not? Once it's done, it's even worse to change, but it may have actually some benefit in further trial to see if we can do more than this. Then another bias, and I know that's more a worry of the company than the doctor, is that you have, once again, good case, you were ready to start darolutamide or apalutamide, because these are the 2 for which there is a problem. You do a PET PSMA and you see 2 small metastases. Would you say, oh, no, we have not tested darolutamide, it's only no enzalutamide and abiraterone? Is it crazy to say that, or is it a reality? What is the situation in Germany? Are you really strict to show he has no metastasis?
So if you have a patient, we are talking about a non-metastatic CRPC still, right? So if we just take the color away from the PSMA PET that you did, and you don't see the mets anymore, you are as good as you would be without the PSMA information. So,
which is a good recommendation. Yeah. People tend to forget that in PET-CT there is PET. And actually, so for you, as long as you don't show the metastasis, that's okay, you can move forward.
Absolutely. And if you have small nodes in the pelvis, Some people tend to forget about that one, and they are small enough. You wouldn't have metastatic disease as long as the nodes are below the iliac separation. So that's local disease.
And then a more complicated one, because your patient has a slow rise on PSA, PSA doubling time around 1 year. For this patient, there is no indication of darolutamide, apalutamide, enzalutamide. But then you do a PET PSMA, and that PET PSMA show, let's say, 2 bony metastases. But he's low risk. So how do you treat that patient? Would you say, okay, no, that's a low risk. I may give radiotherapy, or it's a low risk, I do nothing, but then why have you done the PET PSMA? Or it's a low risk, but he has metastasis, so maybe I'm going to revisit and treat him for a high risk. What do you do? Because we've got more and more questions with these patients.
So with a low-risk patient with a rather long doubling time, and you have, you said 2 defined metastases.
Too small,
right?
In the bone.
In the bone. Then, of course, we do as much as we can metastases-directed treatment now. Knowing that there is largely an absence of evidence, of good evidence, that's actually leading to an oncological benefit. We still do it, I think, based on the rationale that that patient is not likely to progress very quickly. So we take the chance, we do the radiation on the bone, and we do frequent imaging to find out whether we have an effect. So we have imaging for further controls as well as the PSA. I think you don't do anything wrong by doing this, but you're thinking you might have a chance of delaying progression by doing so. And I think what's important always is to see the whole life journey of this patient. So now you're at a stage where you think by delaying, you can actually delay the start of systemic treatment. And in contrast to the one you described before, where I think you have to, with a very short PSA doubling time, in this patient, I think it's okay to wait to do metastatic directed treatment and then start systemic treatment later when there is a progression on imaging.
Martin, you would agree on that?
Nothing to add on that.
Okay, perfect. So let's move to the metastatic hormone-naive setting. So I did a few advisory boards with Germany, and in Germany you cannot be accused of corporatism because you've been giving chemotherapy yourself. So that's a very nice setting to study this. If I understood well, over the last 2 years in the COVID time, really very high penetration of new hormone therapy, especially apalutamide, if I understand well. ADT plus docetaxel, ADT plus apalutamide in Germany, it's almost the acquired standard of care. When you look at the triplet, what is your view as German urologist? Who would you recommend a triplet nowadays? Know that the way you treat the patient has totally shifted.
I think for that question, we have to go back to 2014 when Chris Sweeney did his talk in the plenary session on Charted. Back then, we started to do chemotherapy, and we learned that treating patients in the MHSPC space is something totally different from the MCRPC space. It's healthier patients. They have less of a journey behind the belt concerning toxicity they acquired, and they're younger. So patients will be more prone to get through the chemotherapy with less long-term toxicity, and they will recover more nicely compared to the MCRPC guys. So back in the day, prior to availability of apalutamide, enzalutamide, or abiraterone from the later trials after Charted, we did quite a lot of chemotherapy, especially in in high volume patients. So why not go back there and treat patients like we did, and adding darolutamide parallel to that with a toxicity which is almost like a placebo effect. So I think it's if we can treat patients like we did with the glasses we had back in the Charted days when we thought chemotherapy is good for those patients, we can still apply that nowadays.
I just follow up on what you just said, and I agree a lot with what you're saying, because I think the indication for triple treatment is very much the same as the indication for chemohormonal treatment, because if a patient doesn't qualify for docetaxel, he just won't qualify for a triple treatment. And that's largely depending on a lot of factors, which is patient dependent. I've had this one patient who just, he's a piano player, and I couldn't put him on docetaxel because he was, afraid of his peripheral neuropathy. So that was one reason why he didn't want to have it. But if you have a high volume patient based on data that we have, now of course we're lacking further sub-analysis of the RSN study, which we will see very soon, I think, who is the patient that is really profiting from triple treatment in that study. But a high volume patient will be profiting, and I will discuss that option with the patient. The one that I don't consider to be a good candidate would be the low volume recurrent patient, because that's the patient where like the one you described, prostatectomy, radiotherapy, recurring, and then having a very low metastasis volume, I think is not the one that is really profiting from that.
Yeah, so because this is something we discussed intensively with Bayer when they had the result. I mean, the result of the triplet, the result of PIS1 and Arescence will not increase the indication of chemotherapy. But it should encourage us to come back in 2014-15, look who were the patient we were giving chemotherapy at that time, and now add something on top of this chemotherapy, which I believe is important, because like you said, it's impossible today to define a patient fit for chemotherapy. I think that with following the Arescence, Matthew Smith and I, we did kind of 20 advisory board, and we have now like 25 definition of who needs docetaxel. And actually the only one that makes sense and comes many times is exactly the one you said, Martin. Try to go back to MDT like it was 5-6 years ago and recommend docetaxel for this patient. No, I don't want this to be a commercial question, but we have 4 agents. And one of the questions that pops up today is to say, we have enzalutamide and apalutamide approved in our institution. It's reimbursed in Belgium. Docetaxel, I mean, they're not even tracking it because it's class 1. They don't know who's got docetaxel because it's so cheap. When we're speaking triplet, do we have to do triplet with abidaro, or we've seen the result of can we extend to enzalutamide and apalutamide? Because the results are not that striking in this study. What's your idea about that? If you do the triplet, does it have to be abi or daro?
I would say if you go by evidence, we would actually have to go for daro or for abiraterone based on Arescence and PIS1. There was only subgroup analysis with very low numbers of patients, especially in the apalutamide trial, in the Titan trial. Only about, I think, 20 patients or so per arm who had sequential therapy. I think, of course, theoretically you could do that, but I would say stick with the level of evidence and go for the phase 3 trials, which were planned to do that.
Even if that wasn't an industry-sponsored symposium, I would not know why I wouldn't be prescribing darolutamide in that aspect. And I showed you my patient, who is my age. I give him the prospect of going through docetaxel, which is tough, but then he knows there's a certain end, and then he's going to put on a drug, which is giving him a very good quality of life. And just that prospect of having that is motivating him to go through this difficult time. So I think having the option of this drug for a doctor is very nice, because you can motivate a patient to go through this defined chemotherapy before you're going to be put on a drug that works really well and is giving you little side effects. Therefore, yes, I would be using it, and I wouldn't know why I shouldn't use it.
Okay, thank you. So if I think we don't have more questions, it's Sunday night.
Sorry. Considering high-risk disease, what is the rationale to the genetic workup before initiating any therapy?
That's a good question, which has been intensively discuss. And as you know, it's now in the guidelines. I don't know what you do in your center. The guidelines basically identified 3 groups of the patient. Those who have a family history, but that's an easy one. I mean, we didn't need guidelines for this. Everybody which is presenting with newly diagnosed metastatic, that we try to do systematically. And then everybody with intraductal and cribriform, that, to be honest, we're not following that one perfectly well. But I think it's important to have the information up front. That's one point. I think at that point in time, my view on this, it's more for a global information than for an immediate benefit for the patient. If you think about immediate benefit for the patient, anyway, if the patient was positive, you know it. But if it's negative, you're going to have to retest it when it becomes castration resistant to be sure it has not acquired the mutation later on. But we try to implement it. We have still a lot of education to be done. But in newly diagnosed metastatic patient, I would consider it as standard of care and to be done. I don't know what you do in Germany.
I agree with what you said. Nothing to add.
Same thing. The only question we have in Germany is that we don't get a reimbursement for testing for those mutations in newly diagnosed patients.
Same in Belgium. Actually, for this, you need to send the patient to an oncogeneticist. We, as urologists, we cannot order the test. We can do it when they are castration resistant to recommend olaparib. That we can do because this is target identification. And we realize that there are not that many oncogeneticists, so sometimes it takes 2-3 months, but that's not a big problem at that stage of the disease. So the answer is yes, and we should do it. Not for them, but for their family, it's very important. Does it answer the question? Then ask another one.
No. It's coming in the issue of the treatment. Also for the patients to put on ABI, for example, ABI with olaparib. That was saying.
Yeah, that will come later on, I think. So the combination, the combo, like the propel magnitude and all of this, I tend to say, we discussed that this morning with Axel Meserberger in a course. I think that when it's going to be a fact, so when it's going to be an option that it's actually approved by EMA, FDA, then indeed we're going to have to do it. In the meantime, I would say you test for information when the patient, or you test for action. And for action, at this point in time, there is only trial in newly diagnosed metastatic patients. So I think in this patient today, it's for information.
It's not cost effective.
Not that we're going to see.
Yeah, and if you have a patient who is who's newly diagnosed and he has never seen ADT so far, even if you find a BRCA2 mutation, for example, you would not be in label to treat him with whatever substance you have up your sleeve. So, but you can put him in a trial. There is trials actually currently recruiting for this scenario.
I have some concerns always when this is brought up. When you do testing without being able to offer him anything based on what you found in your testing. So unless you have a clinical trial, you can put him in. If you don't have anything to offer, patient has high hopes if you do testing because he thinks you have a tailor-made treatment afterwards, but you might not have that at that time point. Therefore, I'd be cautious to do random testing without any specific treatment.
To be honest, it's not different from what we're living with PET PSMA. It's exactly the same to some extent. 2 months ago, I saw a young patient, like 55 years old, a little bit strange. He had like very aggressive prostate cancer a few years ago, denied any treatment, finally progressed, had a Gleason 9 with 2 bone metastases, and he has a family history of cancer. He asked for a commercial test to be done. I don't know where, and he had a MSI status, and based on this, went to see a medical oncologist who started the guy on pembrolizumab monotherapy. Don't ask me, he get the reimbursement or whatsoever, but that didn't work because it was not all these drugs work. So that's the danger we have by asking tests at a time, we don't know really what to do afterwards. With the big difference that we need to screen these patients for genetic counseling. That's different. That's why in Belgium we advocate not the urologist or the medical oncologist to do it at that stage of the disease, to send the patient back to the oncogeneticist. And if the patient is found with a BRCA1 or BRCA2 mutation or another one, we had a patient with a spot mutation recently, then the oncogeneticist will come back to the MDT, discuss the result and say, what do you do now? The few we had in the last 2-3 years, because it's not a lot, we decided not to change the treatment at this point in time. So that's where we are now. But if tomorrow there is an OS benefit with Propel, we're going to change the way we treat these patients. That's clear.
But it would be important for the kids of the patients.
Yeah, that's why. That is the reason why we do it.
Yes, exactly. I was exactly about to say that. I mean that, you know, it's been said controversially, this final statement. I mean that, you know, as soon as you say to the patient that the need for undertaking genetic counseling is for threefold reasons. One is obviously to see whether there's a prognostic factor. The second one is to see whether it will be in the future eventually suitable for a drug. The moment is not yet accepted and it's not been regulated, but still is with some protocols undergoing. And the third one is obviously for the rest of the family. You know, there are actually substantial reasons to explain and to make the.
But that's why, to me, there is a profound difference between genetic testing, meaning you are, I don't know, 70, even 70, you've been diagnosed with de novo metastatic prostate cancer. That is at higher risk of, so you should see an oncogeneticist to know your BRCA1, BRCA2 status. Or other gene status. It's not BRCA1, BRCA2 only. And then there is targeted identification, which is different. Somebody will progress slowly and then becoming metastatic CRPC. One of the options nowadays is to give him a PARP inhibitor, and then at this time it should be retested. But then there is all that discussion. If the patient has not been tested for germline before, for instance, I would be in favor of first to do tissue testing, not to lose any of these germline mutation, and if it's positive, then go back to the gene testing. So that kind of articulation between pure genetic counseling and target identification still have to be monitored.
Yeah, I agree. Yes, I agree. But obviously, this is very important anyway. There might be a bank or a structure or substructure where all this information are stored actually, because this will obviously create data that might be useful for the future. So
that's a really good point, because I think that's what we are lacking. We are like a very descriptive list of what we can find in testing, but for the specific patient, it usually has no practical advantage. And I'm always concerned about, you know, raising hopes when you're testing and then there's nothing to offer.
It depends on you, what you say to the patient.
Yeah.
There is that big initiative from Movember, which is actually doing that. It's a large study run by Dan George that is going in many countries when they get blood from every patient which is diagnosed with prostate cancer. And they're collecting a lot of this. And I'm sure that within a few years they're gonna come with a list of what I call the usual suspect. The usual suspect being those mutations that are very important to know for your family or for your kids, and those that may be needed for immediate or further treatment, because that's going to be more and more important. Thank you so much. I think we have to stop here. Amsterdam is waiting for you. So thank you very much for all of those that attended the symposium. Thank you to you, Christian and Martin. And hopefully we see you at next EAU in 1 year. And tomorrow morning for more data on the Arescence. Everything we haven't said today, we're going to say tomorrow morning. So thank you very much for your attention.